Welcome, everyone. Today's one of our Badger Bytes presentations for Grand Rounds.
Thanks, Laura. So good morning, everybody, and thank you for joining us in this, I think, third presentation of Badger Bytes this year. This was a really interesting idea, I think, developed by Manish, and a bunch of us got together over the summer and conceptualized these presentations. So today's presentation is going to be focused on some research projects that are going on in our department around opioid use. It's a really interesting group of diverse projects presented by researchers kind of from across the spectrum. We've got a medical student, Erin Nacev, who I'll introduce a little bit more right before she speaks. We have Emily Buttigieg, who is a fourth-year resident. And we have Lisa Barroilhet, one of our associate professors in GYN. So really excited to have you all here, and I look forward to the conversation that we're able to have after their presentations. So our first speaker is Erin Nacev. She's a fourth-year MD and PhD student, one of our very own students here at the University of Wisconsin. She completed her undergraduate degree in biology from Swarthmore College, and she is currently applying to become a resident in OBGYN. She's been working with me since her summer Shapiro project as an example of how instrumental that summer experience can be in shaping students' work and research and trajectory in research and in clinical care. And I'm very excited to hear her presentation. She'll be talking about a project that we've been working on together. So without further ado, I'm going to turn it over to Erin.
Thank you, Deb. Let me pull up.
And we'll switch screens here.
Awesome. Thanks, Lisa. All right. Oops. Sorry. Start. Awesome. So thank you, Dr. Ehrenthal. I'm excited to be here today to talk about our project that we've also been working on with Daphne in the department and Dr. Kirby from the University of South Florida. So just a super brief outline of what I'll talk about today. I'll give a background about opioid use disorder during pregnancy and its treatment, talk about our methods and the unique nature of the Big Data for Little Kids data set, and then some results and preliminary results of future projects as well. So diving into some background. Studies in Wisconsin and across the United States have shown rising rates of opioid prescriptions during pregnancy and opioid use disorder diagnosis during pregnancy. Opioid use disorder is typically documented and studied at delivery hospitalization using hospital discharge data. Neonatal abstinence syndrome, or NAS, has also been rising across the United States. Importantly, policies regarding substance use differ by state, and this just has implications for observational data. As you can imagine, with statutes that criminalize substance use during pregnancy, it might influence documentation, which is where our claims data comes from. Prenatal opioid use disorder has been associated with adverse infant outcomes such as low birth weight, preterm birth, and of course, neonatal abstinence syndrome. Data and studies on how treatment of opioid use disorder during pregnancy affects those outcomes across the population is limited. There has been some smaller cohort studies that show some improved outcomes with buprenorphine treatment in particular, but on a scale like our data allows us to study, that has not been yet done. So just to show some of those national trends, this graph is national hospital discharge data. And as you can see, just a really substantial growth over the last, since 1999, over the last 20 years or so. And breaking that down by state, you can see from this map, it shows the darker blue are the higher rates of opioid use disorder, and the lighter colors are lower rates. And Wisconsin is sort of right in the middle of that. And so it makes it a good place to be studying this. The recommended treatment for opioid use disorder, both during and outside of pregnancy, is medication-assisted treatment, which means either a prescription for methadone or buprenorphine combined with behavioral therapy. And that's just to orient to some of what we'll talk about in our data. And treatment access in Wisconsin, this map shows where people are able to access that medication-assisted treatment. So the orange dots are all buprenorphine waivered providers across the state. And so you can see in recent years in particular, that access has expanded in rural areas in particular. But the blue dots on the map show where pregnant people are able to access that care. And it is concentrated mostly in urban areas. So our study, what we're setting out to look at with this data is what is the prevalence of prenatal opioid use disorder and what is the uptake of medication-assisted treatment among Medicaid-covered births in Wisconsin? And furthermore, what is the association of opioid use disorder and treatment with infant outcomes across the state? So I'll dive into the methods. So the overarching project and data set is called Big Data for Little Kids. And the core of that data set are birth records of Medicaid-covered births in Wisconsin. Those birth records are linked to Medicaid claims, encounters, and prescriptions, geographic data, Department of Public Instruction data, which includes some standardized test scores, and then the Institute for Research on Poverty multi-sample person file, which includes data on accessing social services, incarceration, those sort of things. Our methods of opioid use disorder identification are unique because of this Big Data for Little Kids data set. We're defining opioid use disorder as a diagnosis, an ICD-9 or 10 code in claims data, a prescription claim for MAT, so methadone or buprenorphine filled during pregnancy, or a procedure code related to opioid treatment. And the Big Data for Little Kids data set also allows us to look at people longitudinally. So anyone who's given birth during the time period of our data, which is 2008 to 2016 currently, we have data for all of their claims during those years. But for the purposes of what I'll talk about today, we're just looking at pregnancy. And I broke it down here between pregnancy and hospitalization because we're able to kind of look at those separately and together as opposed to some other studies that are just looking at hospital discharge data. So some results of our study so far. Among Medicaid-insured resident occurrence live births in Wisconsin during that time period that I mentioned, 08 to 16, 1.4% had an opioid use disorder diagnosis during pregnancy. And this is a population of about 230,000 births. That increased substantially over that time period from 0.8% in 2008 to 2.1% in 2016. This graph shows the prevalence of opioid use disorder during pregnancy by year, also including 2007 here. These darker green bars show the diagnosis during the period of the delivery hospitalization. So this is not entirely equivalent to hospital discharge claims, but we are approximating that time period while the person was hospitalized. So I'll add some bars on top of this. These lighter green bars show the additional prevalence that we get when we include claims during pregnancy. So all the people included in these lighter green bars did not have a diagnosis during the delivery hospitalization. So you can see this nearly doubles the prevalence of opioid use disorder among pregnant people. This graph is showing the prevalence of NAS among infant claims. So the red line shows the prevalence of NAS during the hospitalization of the infant, and the yellow is a NAS diagnosis ever for that infant. So this yellow area is a NAS diagnosis after the initial hospital discharge. And we thought it was notable that this yellow area is sort of narrowing over time, indicating perhaps that we may be getting better at identifying NAS during the initial hospitalization. This graph shows the proportion, rather than of the entire population, but the proportion of the OUD population who received medication-assisted treatment during pregnancy. So the darkest line are those that received any prescription. The next line is any prescription during second or third trimester. And then the lightest line is any prescription during all 3 trimesters. So this is just our crude way of approximating treatment consistency over time. And all three of those groups have increased during our study time period. And on the flip side, those that have some sort of untreated opioid use disorder during pregnancy or no MAT prescriptions, that line is decreasing from almost 60% down below 40%, which is promising. A couple other findings. Prenatal opioid use disorder was associated with adverse infant outcomes in our data set as well when controlling for contextual factors. So that included low birth weight and preterm birth. In the future, we're planning to look at the association of Medicaid-assisted treatment with infant outcomes, answering the question, does engagement with treatment, methadone, compared with buprenorphine, mitigate adverse outcomes? And what we've seen so far in that data is that the outcomes for those two different groups are actually quite different, and we're seeing much improved outcomes with buprenorphine compared with methadone. And I mentioned here as well that because methadone and buprenorphine are so different, and the ways that people engage with those treatments are very different and perhaps have different selection involved, that we are employing some quasi-experimental methods such as propensity scores and inverse probability weighting to try to sort of approximate an experiment and account for some of that selection bias. We're also hoping to look at the bounded prevalence of opioid exposure during pregnancy using the same data set. So not just opioid use disorders, but also exposure to non-MAT opioids during pregnancy. So these are some acknowledgements, just the funding provided, and then the different departments at UW who have helped with this project and my references. Thank you.
Great, thank you, Erin. And we'll have a chance to ask questions at the end of all of these presentations. Our next speaker, who I think is going to be putting up her slides as I introduce her, is Dr. Emily Buttigieg, only a fourth-year resident in our OBGYN program, who is graduating later this year. She did her undergraduate training at the University of Michigan with a major in biology and a minor in peace and social justice. She completed medical school at Vanderbilt University before joining us here in Wisconsin, and she's going to talk about some research she's done during her residency looking at opioid use following surgery. So this is a really nice tie-in. I think we understand there's complex multiple pathways into that people arrive at opioid use disorder, and certainly use of opioids around surgery is one of them. And I really like to tie into the first project. So I'm going to turn it over now to Emily.
Perfect. Thanks so much for that introduction. Can everyone hear me and see my slides okay? Perfect. Thank you. All right. So I'm going to talk briefly about some of the research I've done looking at opiate use following benign gynecologic surgery. So some background, I think Erin did a really nice job kind of laying this out. As we all know, this is becoming a huge issue. Back in 2017, the U.S. Department of Health declared the opiate crisis a public health emergency. 4 to 6% of patients who misuse prescription opiates eventually transition to using heroin, another deadly drug. In 2018 alone, over 70% of drug overdose deaths involved an opiate. Here in Wisconsin, we have kind of an issue with this as well, both in pregnancy, as Erin alluded to, and outside of pregnancy. In 2016, there were 70 opiate prescriptions per 100 persons living in Wisconsin, which is a huge number. There was a total of 4 million opiate prescriptions that year and 827 deaths from opiate overdoses. So a lot of work left to be done here in our own state. My research used some prior research out of Dartmouth as kind of the basis for our study. This was performed in the Department of General Surgery. They looked at 5 common surgeries performed in their field. They surveyed patients retrospectively over a 6-month period, looking at the number of pills they used versus the number of narcotic pills they were prescribed. And they found, not surprisingly, that patients only used an average of 28% of the number of narcotics they were prescribed, leaving the remainder out in the community for potential misuse. They then calculated the number of pills needed to cover about 80% of patients' reported needs. They presented this initial study to their department and then did a follow-up study and found a 53% reduction in the number of opiates prescribed, with only one patient needing a refill. And so this greatly reduced the number of opiates in their community, with still good pain control for their patients postoperatively. So the objectives for my study were to look at our own opiate prescribing patterns here after benign gynecologic surgeries, and this was at Moderator. I then hoped, similar to that prior study, to estimate an ideal number of pills needed to prescribe in order to align with about 80% of patients' reported needs, and overall, again, reducing the number of unused opiates in our community. So this was a quality improvement project. I did a chart review of the electronic medical record, looking at the medications prescribed, both opiates and non-opiates, assessing if patients needed any refills, and also collecting basic surgical details. I then sent patients a survey via text message on postoperative day 7. This survey was a quick 5-question survey looking at the number of medications people used, again, both opiates and non-opiates, as well as their overall satisfaction with their pain control. In total, I sent 420 surveys, and I got 172 responses. On the right, you can see a breakdown of all the different surgery approaches that were used during this time period. Similar to that other study, I separated this into about 5 categories, so excluded 30 of those surgery approaches. My main categories were hysterectomy, both a laparoscopic and vaginal approach, laparoscopic surgery that did not involve a hysterectomy, vaginal repair surgery, operative hysteroscopy, and then suction dilation and curettage. Looking first at my outcomes in the hysterectomy patient population, on this graph, you'll see on the y-axis, we have the morphine milliequivalents, and on the x-axis, we have the surgical approach. On the left, we have laparoscopic or robotic, and on the right, we have vaginal. In the blue bar, you see the number of morphine milliequivalents prescribed. And in the orange bar, you see the number of morphine milliequivalents that patients reported using. In the gray bar, you see the 80th percentile of patients reported use. And you can see, as indicated by the star, there was a statistical significance between the number of prescribed narcotics and the number used, with patients using less than we were prescribing for both approaches. Looking at the remaining non-hysterectomy surgeries, this graph similarly has morphine milliequivalent on the y-axis and surgical approach on the x-axis, the number of prescribed opiates in the blue bar, the number reported used by the patients in orange, and the 80th percentile in gray. And what you see again here is a statistically significant difference between the number of prescribed and the number of used, both for laparoscopic surgeries and for vaginal repair surgeries. There was no statistical significance found with those patients who underwent operative hysteroscopy or suction D&C, with the majority of those patients not receiving any narcotics at all. So based on this, similar to the other study, I did calculate what the 80th percentile of morphine milliequivalents would be, and then stratified it out by some of the more common narcotics that we prescribe. Overall themes from this table is that after operative hysteroscopy and suction dilation and curettage, no narcotics are recommended. Following a laparoscopic approach, about 20 pills is recommended. After a vaginal hysterectomy, around 15. And after laparoscopic surgery without a hysterectomy, somewhere between 12 to 15 tablets. After a vaginal surgery, less than 5 tablets were needed to cover 80% of a patient's needs. I then moved to a sub-analysis to see if there was any difference between patients who had endometriosis and those that didn't. So on this graph, again on the y-axis, you have the morphine milliequivalents that were either prescribed or used. Looking at the chart on the left, this is patients who underwent a laparoscopic surgery without a hysterectomy. In the green bar, you have patients with endometriosis, and in the blue bar, you have patients without. And what you see both for laparoscopy without hysterectomy or laparoscopic hysterectomy, there's no statistically significant difference between patients' prescription or patient use in those with and without endometriosis. So there's not a subset of people with endometriosis that are using more narcotics or being prescribed more narcotics within this data set. Additionally, I looked at our use of non-narcotics, which should be our first line for pain control. In total, 64% of the patients in the study were prescribed some form of non-narcotic pain medication. That included Tylenol, ibuprofen, gabapentin, or Lyrica. And 68% of patients reported taking some form of non-narcotic pains postoperatively. Most of our patients, unsurprisingly, are taking some combination of Tylenol and ibuprofen, with a few others taking some additional medications, including gabapentin, Lyrica, or diclofenac. So definitely some room for improvement here, given that not all of the patients are taking these non-narcotic medications. Overall conclusions from the study: following benign gynecologic surgery, the majority of the patients for all of the procedures except operative hysteroscopy and suction dilation and curettage are taking statistically significantly less narcotics than we're prescribing them. And overall, patients did report a satisfaction with their pain control postoperatively. Therefore, to decrease opiate prescriptions here in our community, I suggest an initial prescription needed to meet the needs of 80% of patients, as was outlined in that chart. Furthermore, I think we have some room to improve our patient education in the use of scheduled non-opiates as a first-line treatment, and that's with scheduled ibuprofen and Tylenol. Following this study, I plan to send out this information in kind of a more formalized manner, and then repeat my study in the spring to assess our narcotic prescriptions. I'll also resurvey patients to assess their overall satisfaction and look at patient refills to ensure that that's not increasing with our decreased prescriptions. So I'd like to thank Dr. Heidi Brown, my mentor for this project, as well as some research assistants, Dr. Tierney and Maria. Thank you.
Thank you. Another terrific presentation. Thank you so much, Emily.
Thank you.
And we're doing really well on time, which I'm happy about. Our next and final presenter then is Lisa Barroilhet, who really needs no introduction. She's an associate professor in our department in GYN oncology. Her current funding and research focuses on ovarian cancer prevention, and she's also interested in improving surgical outcomes among women with gynecologic cancers. So Lisa, I'm gonna turn it over to you.
Thank you. Thanks for the introduction. Everyone can see my slides and hear me. Okay, I see some nods. Those were two fantastic presentations. I am proud to be the weakest link in this trio. So I'll talk a little bit about opioids, cancer, and the immune system in an attempt to untangle a complicated relationship. We're going to try to conceptualize the impact of opioids on cancer behavior after this brief presentation. We know that cancer causes pain. That's probably the most obvious statement anyone's made today. And for the purposes of this talk, I am focusing on ovarian cancer as it's most applicable to particularly the surgical piece of this presentation. We know that ovarian cancer patients often present with ascites, a significant tumor burden, and are then asked to undergo a large surgery and chemotherapy. Chemotherapy-related toxicities can be painful, and patients often will suffer from bowel symptoms that can be very uncomfortable as well. I personally prescribe opioids very liberally in my practice throughout patients' treatment course, and have thought a lot about how other methods of pain relief and how those potentially could be used more effectively, as well as things besides opioids that we should consider, particularly surrounding surgery. So we know that opioids relieve pain, which is fantastic. We also know it's important for patients to be comfortable, but there is a price that is paid for this pain relief. Opioids, and this is completely separate from issues surrounding addiction, which are obviously real and have already been touched upon. Opioids are immunosuppressive. They increase inflammation. And from the standpoint of a cancer physician, that's particularly worrisome. We know that inflammation can be, it's like lighter fluid for cancer, right? It's one of the pieces of the tumor microenvironment that's most consistently seen throughout tumor types. So increasing inflammation is something that we desperately want to avoid. Opioids also modulate angiogenesis, meaning they can help cancer be able to more adeptly grow new blood vessels, which helps them grow larger, metastasize, invade. And we also have learned that opioids surrounding the time of surgery can be a particular perfect storm. So general anesthesia, particularly inhaled anesthetics, are immunosuppressive, and blood transfusion, which is another area of study of mine, has been shown to have negative effects on the immune system as well. So when we think about the treatment paradigm for ovarian cancer patients, we're really putting them in a very vulnerable situation. We're talking about surgery, releasing cytokines. I can't think of a debulking procedure more inflammatory than what we do to ovarian cancer patients, especially the way that cancer tends to disseminate throughout the peritoneum. It's not like an en bloc resection of a colon cancer. It's a totally different thing. And certainly we're giving the tumor a lot of exposure to the abdominal cavity. There's going to be inflammation, cytokine release, etc. So this diagram attempts to depict the complicated relationship between surgery, physiologic stress, pain, and cancer. We cannot break this down entirely, but we need to acknowledge that pain and inflammation are going to be positive for cancer cells. It's going to promote growth, metastasis, and invasion, and that stress is going to be damaging to the immune system, as is pain. So it's really difficult to control this all of these factors surrounding surgery, but you can try to improve pieces of them. So using NSAIDs, we know that's something that can be effective for pain control. It's not appropriate for every cancer patient after every surgery, but certainly that can decrease pain and inflammation. The use of local anesthetics can also be helpful. Opioids, perhaps avoiding them. We know those are going to promote the growth of cancer cells and potentially impair immune function. Volatile agents like the inhaled anesthetics I've been talking about, so perhaps using IV-only anesthesia. That's something being studied actually in our anesthesia department right now, particularly for cancer patients undergoing resection. So we think this is related to the mu receptor. Opioids have multiple receptors, but from a cancer standpoint, it seems that the mu receptor, which is located on the surface of many adenocarcinomas, including colon cancer, breast cancer, ovarian cancer, specifically triggers cell growth, proliferation, and invasion. It's also been studied that patients who have an increase in mu receptor expression tend to do worse from a cancer outcome. Now, that's really difficult to control for, but it has been shown consistently among throughout different cancer subtypes. So it is an interesting piece of the data to note. So when I think about ways to potentially reduce opioid, at least systemic opioid use during surgery, and potentially mitigate some of this pro-inflammatory cytokine release, we think about potentially using regional analgesia, so an epidural for the case of ovarian cancer. I would guess that almost everyone who's listening to this is very familiar with using epidurals, at least for labor pain, but we also use them a lot during abdominal surgery. This is by placing a very small catheter in the epidural space, which is where pain receptors essentially initiate from the spinal cord, and delivering not just local anesthetic, but low-dose opioid directly to that space. So this is kept in place during surgery using a whole lot of tape, but the needle's not in there, right? It's a very flexible catheter. Patients tolerate this really well. And there's a lot of data supporting that it works. So it works from a pain control standpoint. I don't know whose phone is ringing. If someone can mute Dennis, that would be great. I don't think I can quite do that.
Hi, Dennis. My name is...
Thank you. So we know epidurals work from a pain control perspective, and this is not replacing general anesthesia, right? These patients still have to be completely asleep, but it's using an epidural for postoperative pain control and even potentially intraoperative pain control. So that's going to work well as an adjunct for pain, but what is it actually doing to the immune system? And this has been studied not just in ovarian cancer patients, but in healthy patients and patients with a variety of conditions. But patients in general who receive epidural analgesia, when combined with general anesthesia, when compared with patients who only receive general anesthesia, you see better NKCC, so that's natural killer cell function. You also see these are good parts of the immune system, IL-10, IFN gamma. These are parts of the immune system we want to be functioning while surrounding surgery. And you see some of these lower cytokines and interleukins that tend to promote inflammation in patients with epidurals. So, and we have data, prospective data from other cancers that make us think this might also be a good idea. Breast cancer in particular. So this work is actually more than 20 years old, but it was studied prospectively, which is rare in terms of pain interventions, looking at paravertebral blocks in breast cancer patients undergoing mastectomies, lymph node dissections, etc. So very different from epidurals in terms of location, but conceptually similar, using the brachial plexus and numbing those nerves rather than the epidural space. But this has consistently been shown. I just gave the reference for the biggest study, but this has been consistently shown to improve breast cancer outcomes. And we think it's because they're using less opioids surrounding surgery. So this has really stemmed a whole chapter of new research thinking about regional blocks and cancer outcomes. So I will say what has been done in ovarian cancer is largely retrospective, and this data, retrospective data on pain control, is very muddy. And I will say that some retrospective studies have shown no survival benefit in patients who have had an epidural analgesia at the time of surgery. But they didn't control for many other things. NSAID use, which obviously could be positive from a cancer standpoint, and it's very difficult to know what kind of anesthesia these patients had. This is very brief, but basically these two big retrospective studies show that patients who received an epidural, particularly intraoperatively, so they were using the epidural during surgery as well as postoperatively, did better. And this is two survival curves supporting that. Again, retrospective data, very, very difficult to tease out if it truly was the analgesia choice that made a difference for these patients. But they did control for tumor burden, for debulking, for chemotherapy, the big things for stage of cancer, patient age, the things that typically affect cancer outcome. When we think about trying to answer these questions, we do have a prospective study here. The study's been going on for years and years, and we have 10 more patients left. So this is actually a question we're going to have answered, I hope, soon. And it's randomizing patients undergoing gynecologic surgery, so midline laparotomy, to getting an epidural versus not. So it's hard to accrue to the study, right? This is a pretty invasive intervention, and you're telling patients they are going to be randomized to either having an epidural versus none. And patients usually have an opinion about that. Now, everyone's getting our standard enhanced recovery pathway. So of course, everyone has access to what we consider the best postoperative pain control. So these patients are going to be on the ERS pathway. Half of them will get an epidural in addition to that. So the primary outcome is actually looking at pain scores. Epidurals have fallen out of fashion in the enhanced recovery era, and we've never really investigated if we're losing pain control benefit, particularly in a gynecologic population. But we're doing some really interesting translational correlates, and there are many cancer patients who've been enrolled in this. So we can look at serum cytokines at baseline, the first postoperative day. And we can even look at them further out because we have biobank specimens that can be examined. We also are looking at salivary cortisol levels the first day after surgery, which is the best marker we have for physiologic stress in these patients. So we're going to try and learn a little bit more about what different types of anesthesia and analgesia are doing in terms of immune function surrounding surgery at different time points. Now, it's not just cancer patients included in the study, but we hope to have enough that we can at least look for patterns and areas of further study. I've definitely gone over my time, and I hope you'll forgive me. But in conclusion, our use of opioids in cancer patients probably needs to be reimagined, and we at least need to consider the possibility that around surgery in particular, that we could be harming patients when the immune system is the most vulnerable. Regional analgesia may be part of a paradigm to improve the tumor microenvironment in a more favorable manner, especially again in the perioperative period. Thank you for your attention. I'm going to stop sharing, I think.
What a fascinating presentation. And I think as a trio, it was a great coverage of a lot of the important issues around opioids and women's health. So we're going to have an opportunity now to have some discussion and questions. And while people are typing theirs into the chat, I'm going to start with my question. And this is a question for both Erin and Emily. And that is, we know there's a lot of variation in medical practice and medical care. And it can vary by provider characteristics and patient characteristics and region and local culture. And I would love to hear from each of you if you have learned anything from your study about differences in practice. Erin, you showed a nice difference in access to treatment facilities, for example. Emily, you're seeing a pretty wide variation, I think, in prescriber practice with narcotics. And I'd like each of you to talk about, if you found anything interesting that helps us understand what it might underlie that variation. And Erin, maybe you can go first and then Emily.
Sure. So there we do see some variation geographically in our data. The between MAT treatment, the buprenorphine is slightly more commonly prescribed for rural residents, and methadone is more common among urban residents. Overall, we do see disparities in access to MAT for any MAT regardless of type. Non-Hispanic Black mothers were less likely to receive treatment, about 30% of those with OUD, compared with between 50 and 60% for non-Hispanic White and Hispanic mothers. So there's certainly variation in how people are getting treatment, at which treatment, and where. So definitely more to explore, and I think we have a lot of opportunity with our data set.
In regards to mine, my study is limited to Wisconsin. In medical school, I trained in Tennessee, where there was also a large issue with opiates, although I wasn't as familiar as a medical student with how many narcotics people were being prescribed. The variation I see in my data, most of the prescriptions are being placed by residents. And so you can kind of tell in the data study when the resident team switches and what different people's preferences were. I didn't actually kind of pair out the different kind of PGY levels, but I wouldn't be surprised if, especially since my data is a few years older now, some of those older residents were still prescribing higher amounts. And now with all kind of an extra focus on it, the younger residents are doing more kind of careful prescriptions. I think someone asked a question also about the same day discharge. It's a very interesting question. Obviously, at the time that I ran my study, in general, people getting hysterectomies were staying one day. And then people with minor surgeries were going home the same day. I asked patients in the survey how many they used, but I'm not exactly sure, thinking through this with Dr. Brown, whether they counted the number of pills they took in the hospital or whether they just just reported how many they took since they had discharged. My guess is probably the latter, but, I can't say for sure. And so it will be interesting now on retrospect to see how this changes if we're continuing the same day discharge. And then the other question on the endometriosis, this kind of was fortunate with the timing of my study. Dr. King was kind of finishing her tenure here. And so she had quite a high surgical volume at that point. And so we wanted to make sure that given the higher population of her patients in that there wasn't some bias towards the endometriosis. So something we had talked about a little bit before, but then looking at kind of the surgeon numbers, wanted to make sure that there was no bias there.
Really great, really interesting. And it sounds like there's a whole lot more to come for both of these projects. Thank you. There are some questions in here for Lisa. And they're kind of scrolling by, but still sitting at the top of my screen, is a question about studies about the impact of various components of the ERAS pathway on tumor biology.
Yeah, that's a great question. So the aspect of ERAS that has been best studied in cancer is the use of NSAIDs. And NSAIDs have been studied for cancer prevention, for postoperative pain, for cancer-related pain at different points. And it definitely, in general, is positive in terms of decreasing inflammation and improving cancer outcomes. It's actually the colorectal literature that's the strongest. But other pieces of what we typically use in ERAS, such as gabapentin, we use some very specific antiemetics intraoperatively, dexamethasone, for example, or Decadron, Haldol, or similar. Those have not been studied. I think in general, ERAS probably is going to be shown to be beneficial to tumor biology because what you're doing is trying everything on earth to limit opioids, particularly IV opioids, and to get the patients moving and behaving normally as quickly as possible after surgery. But different components have not been tested individually that I've seen.
Thank you. Manish, you have a very interesting question here. And rather than reading it, I wonder if you could unmute yourself and kind of share your thoughts.
Okay. Yeah, can you hear me? Well, first of all, thank you so much to all three of you. Wonderful presentations. I learned so much. Um, I'm looking at it from a biology lab-based kind of perspective. Um, with pregnancy and opioid use, it leads to decreased fetal growth. Whereas in the cancer setting, it actually promotes cancer growth. So there is kind of a dichotomy there because in fetal growth, we need angiogenesis and so does the cancer. So I think there is a lot to explore in that sense, both from an angiogenesis perspective and immune perspective as well. So I didn't really have a question there, but I just wanted to introduce that and see if what people think and if maybe something that we can explore together. Thank you.
I'll just mention one thing in kind of thinking about that comment question is just in our analysis, we see an association, and there's been an association in the literature between opioid use disorder and low birth weight, but there's all sorts of things that are wrapped up in having a substance use disorder and opioid use disorder. So I don't want to say that the opioid use in our data is causing low birth weight. Exactly, yeah. So, for example, 75% of our the opioid use disorder population also use tobacco during pregnancy. So we control for some of those things, but even so, we can't control for everything. And so I think it's a super interesting question, but want to just make sure that not implying causation here.
Thank you. That's a great point.
Alex,
Great.
would you say your comment? I think that's like really interesting, and I'd like to hear more.
Sorry, was that directed to me? I didn't hear the beginning of what you said.
No, I was hoping that Dr. Stanek-Kostek would like elaborate on his proposal about opportunities to determine cytokine levels and cellular immune system programming.
Hello, everybody. Just give me 1 second. Okay, I figured it would be hard to talk to the mask. So, Lisa, first of all, just really fantastic talks by everyone. And I have questions for Lisa because, as everybody knows, I'm biased towards the immune system, right? And so along those lines, I think it's really important to ask the question about what happens with immune cells in a local fashion versus a systemic fashion. And especially in cancers like ovarian cancer, where there's ascites and, Lisa and Manish and I have published on this stuff together before in a fabulous fashion, right? And so really the question is, could we access and study immune cells locally either via IP catheters or in second look surgeries in the context of opioid use and or in the context of randomization to different interventions?
I have no words to describe how much I love that idea. I feel like I became interested in the tumor microenvironment in exactly the wrong time because IP catheters being placed for chemotherapy now is exceedingly rare after some recent larger studies being published that didn't support, that supported much more toxicity and perhaps not the survival benefits we'd hope for. Although many argue that in the right patient, IP chemotherapy is still incredibly valuable. I will say, and I'm sure you guys have noticed this on your gyn-onc rotations to the residents, that we don't do it much. So that, and also some recent data showing that second look surgeries are not as helpful for long-term outcomes as we hoped they were, and that chemotherapy, particularly with specific agents, might actually be better, make me think that our ability to do that is going to be pretty limited. I think those are really outstanding suggestions because my guess is a lot of what we see systemically is not actually what the ovarian cancer cells are living. And ovarian cancer in particular is so fond of the abdominal cavity and the peritoneum and is so adept at figuring out how to live dormant right, during these long remissions we see in patients and then somehow come roaring back, that I think you're right that without a way to sample that and figure that out, we're going to be a little limited in understanding this unique cancer's behavior.
Thank you. I'll just add one other food for thought here, and that is that I think increasingly in the field of cancer immunology, we are learning more about how individual T cell receptor and B cell receptor repertoires adapt and are shaped by the tumor microenvironment, and clearly immune cells traffic between the tumors, the tumor itself and the circulation. And just as a plug for things that we could do in proposals and pilot projects is the idea that we could actually track individual T cell receptor anti-tumor specificities and see how they're actually affected by this. And along those lines, try to determine which of these cells are actually the ones that are trafficking locally. So you can actually study in the blood potentially the intratumoral T cells. But Lisa, awesome work. Thank you so much.
Thank you for that really thoughtful commentary and question.
So I'm going to swing back to healthcare delivery, and I'd love to hear from Emily, kind of based on the chart review. You talked a little bit about where you'd like to take this, but I'd love to hear a little bit more detail and, kind of what you think, kind of how you might understand what's driving people's prescriptive behaviors and how you might want to have an impact there.
Sure. I think some of the improvements that, kind of we were planning to make as we initiated the study have already kind of been made just naturally with everyone recognizing this as an issue. And so I think our chief residents this year, Dr. Larson and Peace, have created a standardized kind of discharge instructions that we now insert in everyone's chart going home that actually spell out dosing for Tylenol and ibuprofen and recommend that as a first line. That was something that wasn't kind of standardized before, and so different patients would get different instructions if they got any kind of at all, really spelling that out. And now kind of following this, everyone has that spelled out, or following that initial study. And so the hope is that giving patients the actual dosage and instructions will help them. Additionally, PACU also now types in kind of a much longer description of like, your last Tylenol dose was at this time, so your next due at this time, and really lays it out for patients. And so I think that education piece postoperatively is really going to help people. The other plan would be kind of spelling out kind of these recommendations and data and giving that to all of the providers, especially since not everyone is here at this one, including our kind of private practice physicians, and kind of talking through what we'd recommend. And then just encouraging residents to talk with providers at the end of each surgery to discuss what we think is an optimal prescription for each patient. It does need to be individualized somewhat to patient needs and complication, and the surgery details itself, but it's a conversation we should be having after every surgery.
That's terrific. And there are a couple of comments in here about some different providers' approaches and success. I wonder if either Bhagavath or Ellen want to speak to that.
I guess I would just say that in my years in the field and having had several gyne procedures, laparotomies and laparoscopies, C-sections, and then a broken shoulder, I was putting a little personal perspective. But to comment on what you're saying, I think that our trainees, when they first come in, they've not necessarily had these procedures. And so there is wide variation, and they often are doing what their senior residents have done. Medical students are doing what their junior residents have done. And I think that, it's brilliant that Emily was paying attention to what's actually happening. And I think that her recommendations are right on target in terms of limiting. And there's been a lot of great studies about limiting narcotic use with other analgesics. And I added in the sort of meditation for pain, because that is something that I think is really underutilized. And so I think the more you can standardize it and sort of have the house staff really understand early on from data-driven, quality study like this, what are people really needing? That, sort of that 15 and that 20, those are great recommendations. And we should have something similar for our laparotomy as well.
I agree. And I think for those patients that do get admitted, there's actually a pain control team that you can consult that meet with the patient and sit with them and talk about like mindfulness, like talking through what you're feeling with pain and how you can kind of cope with that with non-medication interventions. They do aromatherapy and things like that. They've been incredibly helpful in a few patients I've had while on service for the past few weeks. And so I think kind of we should all have a low threshold to consult them and talk with them about some non-opiate interventions because they can be very helpful.
So
it's just a great Badger bite, having a theme and so many different areas and ways to think about it. So great job for all the presenters.
Yeah, I fully agree. We have a few more minutes. And, one of the ideas behind the Badger Bites was looking to ask, is there a collaborative project out there? Is there something that we can look across these different studies and think about in order to kind of move forward collaboratively? And I'm seeing some ideas in the chat, but I wonder if anybody wants to, kind of brainstorm a little bit together about, how to bring together some of this work and build a new project.
So Erin, this one is for you. I'm not sure kind of fully where things are at, but I'd be interested legally in Wisconsin if the laws have changed in your time period regarding criminalizing use in pregnancy. I know that when I was in Tennessee, there was a law and then at sundown, and I'd be interested to know here if there was kind of legal changes and kind of where that falls into your data and how that affects things. So I think that could be a really interesting piece from my advocacy perspective that I think would be really neat to look at.
Yeah, I totally agree. I don't know the answer off the top of my head, but I think we could definitely look into it.
All right, so I'm just going to echo everybody else's comments. These were 3 fantastic presentations, and it's really interesting work, really exciting to hear what's going on across the department. I thought it was a really rich discussion. I think these projects stimulated a lot of enthusiasm and interest across the department. So I guess we can end here, and I'll just encourage everybody, if they're interested, to continue to reach out to the folks who did the presentations to further discuss and potentially envision some future work together.
Thank you so much for leading.
Yeah, that was great, Deb. Thank you.
Thanks, Dr. Ehrenthal.
Well, it's the end of our meeting. Back to real life, and hopefully real life today is more calm than real life yesterday. So it's good to see everybody.